And welcome back to Health Watch. We've been talking to Dr. Ray Jergan about some degenerative arthritic symptoms that the wrist can have and some of the surgical procedures you can do. And I'm always amazed at, talking about the space and the function that you have to maintain. It's the things that you can do now, and it's important for our audience to hear that. So when you left, where were we? I think we...
Well, we just discussed the procedure called a proximal row carpectomy for arthritis that's located between these the scaphoid bone and the radius. Another option instead of that procedure is one where we would remove just the scaphoid bone, but then fuse these four bones together. And there's various ways of doing that. The way I like to do it is by putting a round plate and screws on there. We remove the articular surfaces, take some bone graft plugs from the radius here and put them in between. Then we use this device here, which is a reamer. We place it in there, it creates a concavity, and then we have this little round plate that is placed down into the bone. It's recessed below the surface of the bone, and we have these screws that go into each of the bones, and it all holds together while the fusion is taking place. I have found that to be an excellent operation also. I think that it provides a little better grip strength for particularly a laborer, but it does cause a little bit more loss of motion than a proximal row carpectomy would.
Yeah, I'm impressed about the recurrent need for stability of the wrist as you talk about these surgical procedures and how much of it is ordained to do that.
Yes.
Do you take those, is that a removable device after a while, or do you...
It usually stays in.
You stayed in, it's lifetime.
Right, unless it would cause some symptoms, but fortunately I haven't had to take any out.
Okay.
Yeah. Moving over to the ulnar side of the wrist, there's a couple conditions. One called ulnar impaction syndrome, which we discussed briefly on the previous show, where the ulna bone is too long, rubs against the lunate, and can cause degenerative changes on the articular cartilage there associated with pain. Treatment there involves sometimes an arthroscopic resection. We'll trim off a few millimeters from the end of the bone here, and that allows usually normal motion and reduces the impingement that occurs. Another option, and the more standard procedure, is to make a long incision, take a wafer of bone out approximately 2.5 millimeters, and then put a plate and screws on for it to heal. Now sometimes we'll see arthritis at the radio-ulnar joint. The ulna rotates back and forth in a recess in the radius, and those also are all covered with articular cartilage. Sometimes they can wear out, again, either from just a routine arthritis or post-traumatic, and sometimes that causes painful limitation of rotation of the forearm. The standard procedure for that in the past was to just remove the end of the bone. There are a lot of ligaments that are attached to that part of the bone, and that can result in a significant weakness of grip strength. So we have another device that we can put in to replace the distal ulna, and then we can attach the ligamentous structures to this, and it seems to allow very good, comfortable motion, and it definitely improves grip strength. On the radius side, if we need to, we even have a metal and plastic replacement that can be placed into the side portion of that joint along with the ulnar head replacement. So those have given us a lot of options that were not available previously. And the question is, what if everything is arthritic in the joint and there really isn't limited procedures like this that can be done? Again, the standard procedure is a wrist fusion, and that still may be the best operation for someone who uses their hand hard. But there is also total wrist arthroplasty, which is similar to total hip or total knee arthroplasty, where the radius and carpal bones are replaced. I have the radial component here, and this fits into that surface. I can't quite hold all that together. But basically, this allows up and down motion, side to side motion, and generally is fairly comfortable. The problems with wrist replacements in the past have been that, number one, they wear out, they can loosen, and particularly they can dislocate. The new designs that are that are quite new seem to be doing a lot better with that.
Yeah, it reminds me of the hip replacements that they used to do, and they had the same problem initially,
Right.
and now it's
Just
it's
as
kind
time
of
goes
with a
by, the
minimum.
designs
Yeah.
improve.
Where is the stem of that put in there, if I may ask? Is radius all the way?
This one goes into the radius here.
Okay, so it
and
is right into the radius.
This one goes into the carpal bones.
Right. Wow.
And yeah, and if necessary, we can also at the same time replace the
Sure,
ulna.
makes sense.
So now, as far as the candidates for that procedure, most of the time it's the rheumatoid patient that who is more of a low-demand individual that I would recommend this for. You can do it for degenerative arthritis, but the more active the patient is, the more likely this is to end up failing with time and ultimately requiring a wrist fusion.
Right.
So we leave that up to the patient if they have arthritis, whether or not they would want to consider
Yeah.
total wrist
some of the
versus
rheumatoids
fusion.
I've seen are just, they're so non-functional that anything would improve, that would certainly be a great alternative for them. In the past, we had nothing much to offer.
Right.
But, you know, you and again, putting it kind of it in context, but you've a variety of options that patients can have with arthritic joint, in this case a wrist problem. You alluded to the fact when you would see that patient, you could pretty much make up your mind based on their symptomatology and what you did radiographically. So as you interview the patient, this is what we're going to do, and you have a pretty good sense of that before surgery.
Yes.
And then talk to me about the surgical procedure itself. Is you do this as an outpatient?
Generally, yes.
And they can do that under local anesthesia, or what kind of anesthesia you use?
It depends. If it's a wrist, most of the time it's general anesthesia. Fingers we can do with local and sedation, but the wrist, I think the patients are better off asleep.
Intubated asleep.
Or a breather
Right.
mask. But,
Okay.
but
And-
a lot of patients will do with a regional block or an axillary nerve block with sedation.
Yeah, that's
so
what I was kind of
yeah,
alluding to.
they
Yeah,
don't
no,
have to
you-
go to sleep
Yeah.
if they have medical conditions that are more concerning for general anesthesia.
Yeah, relatively safe procedure from the anesthetic standpoint, and what
Yes.
you end up doing. And excuse me, do you cast these people afterwards, or what kind of post-operative treatment do they require, and what's the normal course?
It depends on which procedure we're doing. Usually, most of them we would put in a splint temporarily until we get their stitches out, just for comfort. Most of these are procedures where we want to start early motion.
Well, right. So
then we would maybe place them in a brace, and a removable brace, have them see the hand therapist, and get started with some gentle exercises.
right. Even the fusions?
Well, the fusion, you can do that, a limited fusion, you can do that. Most of the time I like to immobilize them for a few weeks, but it's not really a long period of time. And by putting this plate and screws in,
Really stabilize it.
it gets instant stability, so we
Yeah.
can start motion earlier.
Good. Well, it just amazes me that what we can do now with some of these joint replacements in particular, but particularly the surgeries you can talk about. Ray, it's always good to have you here. Appreciate coming today and finalizing some of the issues with the wrist. Thank you for
you,
coming, and thank you for watching Health Watch.